Hello everybody and welcome to tonight's webinar for the Society for Acute Medicine. It's great, we've got lots of people joining in to join us tonight from different countries, I'm told. So hello to old friends and to new friends as well. We're particularly delighted that we've got people interested because we're now competing against pubs and restaurants tonight, so that's great. So I'm hoping you're all going to enjoy our fabulous presentations tonight. So this is a programme for this evening. We've got two great plenary talks talking a little bit about COVID with virtual wards and also ambulatory care and triaging to ambulatory care. And we've also got our great abstracts that were accepted for the Society of Acute Medicine conference in London, which sadly had to be postponed. But we really need you to be involved this evening to make it really worthwhile, because we want some good debate and some good interest. So we want you to ask some questions and get involved. It's fairly easy to ask a question. You just press the button at the bottom of the screen. If you can't see it, just wiggle your mouse and it'll pop up. And if you want to ask your questions anonymously, you can do so. And if you see a question and you think, oh, I wanted to know the answer to that, upvote it by just ticking the thumbs up on your screen. So before we get on any further, we want to ask you some questions. So if you use your mouse button to select the answer to the questions, and you can get involved with this as well. So if we can start the poll, first of all, can you tell us what your current role in the hospital is? I'll just give you a little bit of time to answer that. Okay, and you can see here the results showing that we've got a good scattering of the multidisciplinary teams there, with consultants being the most popular attendees tonight. So the next question, please. So if you could just fill in what your specialty is, please. And the results from this showing we've got a good mix of other specialties attending as well. Our next question is going to be about your knowledge of the talks that we're going to have. So if we can have the next question, can you rate your understanding of triage into community of COVID-19, the virtual ward? Okay, and then we'll have a look at that at the end again. And so our next question, this is looking at the understanding of our second plenary talk. And there again, showing the results to that. So now that we've had our poll, we'll go on to our first talk. So it gives me great pleasure to welcome Andrew Walden. Andrew has been a member of the SAM Council representing England, and I'm delighted to say he's not going anywhere because he's now moving on to represent intensive care medicine there. So with no further ado, Andrew, I'll hand over to you.
Thanks, Vicky. Next slide, please. So yeah, I'm going to talk about a pathway we set up in at the Royal Berkshire Hospital, basically to try and manage patients virtually. And I'm going to crack straight on because I haven't got a lot of time. So next slide, please. Next slide. As I'm sure a lot of people at the beginning of this pandemic, obviously the pandemic hit Italy earlier, but there were a lot of WhatsApp groups that were set up, and I was on quite a few lung ultrasound WhatsApp groups, and there's some clinicians that we know in local trusts who also do a lot of lung ultrasound, Italian clinicians, and they started sending around some information and some documents that were coming from Italy. And one thing that particularly we thought was interesting was this triage pathway, which came from this gentleman, Cristiano Pirani from Brescia in northern Italy. And we in Reading, next slide please. Next slide, please. So in Reading, to know that actually we had the first proven case of community spread of COVID admitted to hospital, and it was a lady who unfortunately ended up on intensive care and ended up dying. But that really focused the mind to be very serious. So myself and the middle character here, Joe Noonan, who's the ultrasound fellow at the Royal Berks, thought we would take the opportunity to go up and see if we could punt an idea to our Chief Operating Officer. So we went up and we spoke to the Chief Operating Officer and the Chief Medical Officer and proposed this idea that, you know, if the hospital will become inundated, what we needed to have was a safe way of managing patients remotely. And they listened to us and they said, okay, go away, buy some ultrasound probes, buy some SATs oximeter probes. And so we took them at their word and we ordered 500 pulse oximeter probes and 25 of these Butterfly IQ handheld ultrasound devices. And then what we did was next slide, please. We set up this pathway. So we took the pathway from Italy. We basically got two midwives, Italian midwives, to translate it. We then ran it through a virtual acute medicine governance and a virtual emergency department governance to get some sort of approval for it. And it got approved, and this was actually the final pathway. So I'm just going to talk you through it. So basically, to start at the start of this, the only people that could access this pathway was the emergency department. And what they would do is, when patients came in, they would obviously measure their SATs, and there were three potential streams. So really, the one we're interested in is the green stream. Patients who had low SATs and were suspected of having COVID could stream into a red pathway where they would go to a higher monitor area, either on the respiratory ward or an enhanced bay in acute medicine, or would enter the yellow pathway where they just need supplemental oxygen and go to a ward bed. The patients in the green pathway were patients who had normal saturations. And what we would do, next slide please, what we would then do is we would, next slide, yeah. So what we would then do is we would do two things. We would do a test to check that they did actually have COVID pneumonia rather than just COVID infection. And we would also do some sort of stress test to see what would happen to their oxygen saturations. So we chose a 30-meter walk test because that's what they've done in Italy. And actually, through discussion with primary care, we managed to get that standardized across our kind of CCG, or certainly the primary care or the GB services that we use were involved with the hot hub, which I'll come on to in a bit. And what would then happen is that, so they do this rapid walking test. If the rapid walking test was positive, next slide please, then those patients would then enter onto the pathway, onto the yellow part of the pathway, and a positive walking test was basically a drop in SATs of more than 5%. So they would come in, they go onto the yellow pathway, they'd come into hospital. There were two other possible scenarios. Scenario one was actually the imaging was normal and the rapid walking test was negative. And the majority of those patients would then get sent home with reassurance and with a safety netting to call 111 if they felt unwell or primary care. We did have a rider whereby patients, where clinicians were worried about particular patients, they could still put them on the pathway, but this was a small number of patients. The ones we were really interested in was scenario two, where they had clear evidence of COVID pneumonia, and they actually had a normal stress test. So in other words, we did the walk, and their saturations might have dropped, but not by more than 5%. And what would then happen is those patients would be given a saturation probe, they'd be given an information sheet, and they'd be given the number for the COVID ambulatory clinic, and then they would get sent home. And at the same time, the clinician sending the patient home would take information on contact details and would put a referral through our electronic Cerner system to the ambulatory pathway. Next slide, please. So, as I say, actually, next slide, please. So this was the setup of the ambulatory pathway. So although I'm at the top here, I have to give a lot of credit to Joe, because really he was responsible for making sure that this whole system worked in a fairly seamless way. So he was, like day-to-day management of it. We were very lucky in that we had 3 furloughed middle grade associate specialists from the emergency department. And this was purely done in a cold area, cold part of the hospital. So they were able to give clinical supervision. But really, the workhorses were the PA, the physician associate students who'd been sent home from their course, but were desperate to get involved with some aspect of managing patients during the pandemic. And initially, they did this all free of charge. After a period of time, we managed to get the trust to agree to pay for their shifts. So they got reimbursed at the end, but at the beginning, so they were doing it free of charge. And then we had some extra excellent administrative support from Jack Lord, Connell, who was a final year medical student from Barts, and Sherilyn, who was one of the AMU nurses who was off because of late stages of pregnancy. Next slide, please. So what would happen is that the PA students would ring up the patients, so they'd pick up the list in the morning, they would ring up the patients. At its peak, we had about 50 patients actively being followed up. And they would ring them, and then what they would do is ask a set of scripted questions. So they would ask them about their symptoms, they would get them to talk them through checking their SATs, and then they would do some form of stress test. So we would try and make it as close as possible to the 30-meter stress test. Obviously, that wasn't always practical, so they get the patient to walk around the room, sit down, and then recheck their saturations. And then in a similar way to the original pathway, they could flow, obviously, if their SATs were low on checking, then we would either ring 999 or get the patient to ring 999 and get them to come up to the emergency department. If their saturations were normal and they didn't drop, so the left-hand side of the screen, they would then continue to be followed up for a period of sometimes 5 or 6 days until it was clear they were getting better and they wanted to come off the pathway. And then those patients who had normal SATs at rest but whose SATs dropped by more than 5% were encouraged to come back to the emergency department, but in a slightly more controlled way, so they could, could get driven up rather than having to come to our 999. Next slide, please. We added in some additional sort of iterations of the pathway. So initially it was just ED that referred in. We then involved primary care, which I'll talk about in a second. But we also allowed referrals from the wards to patients who had escaped through or got through the ED into acute medicine who were appropriate for the pathway to get referred from acute medicine. And then also patients who were actually at the tail end of their respiratory illness on the respiratory wards could also get referred onto the pathway if the clinicians felt that they were ready to go home, but they were still sort of borderline SATs. So we had a few from the respiratory wards. We set up a prescription delivery service through pharmacy, and they would also take out SATs probes to patients where they hadn't been given in the emergency department that weren't available. And we set up a phone system which was to a landline, but would, if it wasn't answered on the landline, would then cascade to a mobile phone so that there was always someone available to take the calls. So there were lots of iterations which made the pathway work very well. Next slide, please. Next slide, please. So I think this is one of the real successes of it, was our integration with primary care. This is another success story. What we found with COVID was that it cut through a lot of red tape. And this is the same with these GPs. So in the middle of the screen is Schwann, and then very dynamic local GPs. And what happened was a whole group of GPs, CCG, basically came together and decided that they were going to set up a hot hub, which was in the centre of Reading in what was an existing walk-in unit for primary care. And then staff were borrowed from each of the different GP practices to help staff this hot hub. And from conception to starting was 8 days, which is pretty remarkable. And they had a fantastic system. So what they'd do, a patient would get backed up in a vehicle, whether that be an ambulance or car, would come out of the car, would get greeted by a non-clinical worker who would be in full PPE, who would put the SATs probe on. They'd go up in a lift. The patient would then walk down a 30-meter corridor to do their stress test to the clinical room where they would then get assessed by the GP. So before they'd even had their clinical assessment, they'd already had their SATs tested and a stress test. Next slide, please. So again, a very similar flow, except that the walk test was done a little bit earlier in the pathway. So again, what they would then do is they would do a lung ultrasound because they didn't want to obviously send the patients to hospital for a chest X-ray, but we wanted to prove these patients had pneumonia. And if the lung ultrasound was positive, then they would come onto the pathway. If it was negative, they would, on the whole, send those patients home with a bit of safety netting to ring 111 or their own GP. Next slide, please. So I think this was something that was felt to be a bit controversial at first, was the fact that we were teaching these GPs to do lung ultrasound. And actually what we did was we set up a abbreviated training program, very much on the hoof, where we brought in 4 of the GPs that were working in this hot hub. We did half of their training where we gave them some lectures. We taught them to scan normal models. We took them through some simulations on an ultrasound simulator, and then we took them through some cases and showed them the images. And they were a little bit skeptical and reticent at first, but actually this worked beautifully because we weren't really teaching them to use lung ultrasound in a prescriptive way to dichotomize a rule in. Next slide. So this was, again, this is where technology came in. So this is the butterfly, this is where the butterflies were really useful. It's not just that they're a nice bit of kit, but actually they had this triple encrypted cloud that we could use. So what we did was we gave 3 of these Butterfly IQ ultrasound probes to the GPs because it was going to take too long for them to actually order and get them delivered. So we gave 3 of the Trust ultrasound machines to them and gave them access to our cloud. So what they could do is they could scan patients, they could upload the images with some clinical information, and then they could ping basically an email to myself or Joe so that we could review their images in real time where they weren't sure what was going on. And that was an amazing way to give some real-time feedback, but also to allow us to mentor them remotely in a situation where it would have been impossible to do that at the bedside. Next slide, please. So just very quickly, I'm not going to dwell on this too much, but I just want to go a little bit of data. So we, up to the end of May 2020, we had 244. So we had about another 50 patients referred on. We've actually shut the clinic down now because of the slow. There's really no patients coming in at the moment. But we had 244 patients referred to the virtual ward. And the bits that I want to just concentrate on are the reattendants and the readmitted patients. So 29 patients had reattended the ED, which is 11%. And 18 were readmitted. And this is more through serendipity than anything, but we felt that this was really great because NHSI has guidelines on what is an optimally functioning ambulatory pathway, and they say a conversion rate of around 10% is what you should be aiming for. So we felt that this was right in the ballpark, so we're very happy with that. Next slide, please. This gives you some idea of the demographics. So a higher ratio of females to males, which is kind of what you'd expect because men tended to get sicker and have a higher mortality rate, so would get admitted. We were very inclusive, so we had 2 18-year-olds up to a 93-year-old on our pathway. The median age was 49. And you can see the referral source was predominantly ED, but actually because the GPs came on board a bit later, I think if it had gone on for longer, they would have probably caught up with ED. They referred a lot of patients in, and it saves a lot of unnecessary admissions or attendances to ED. Next slide, please. So this is the baseline data, just to give you an idea. So baseline SATs, 96%, wide range. So the 86% was in a patient discharged from the respiratory wards, and you can see the news scores. So that we thought this was quite interesting because the national recommendations at the time was really that anyone with a news score of 3 or above should be admitted to hospital. But a lot of these were young people who had a tachycardia and a fever, but really not a lot of hypoxemia. And you can see that actually here, if we admitted everyone with a news score of 3 or above, we would have admitted about 40% of the patients to hospital. The swab positive and negative, so there's obviously a lot of missing data there, and that's because at the start of this, PHE guidance was not to swab patients that were being sent home. So there's a lot of missing swabs there. Next slide, please. And again, just very quickly, I thought this was quite interesting because actually if you look at the median D-dimers, ferritins and lymphocytes, it's very, very different to the admitted population. So the patients I was seeing on intensive care all had ferritins through the roof, very low lymphocyte counts, high D-dimers. So this is definitely a different severity of disease. Next slide, please. And this is just to compare those who were readmitted against not readmitted. So there was a slightly higher news score in the readmitted group, but that's probably just a reflection of the fact that they actually had lower SATs on the whole. So I think, again, we need to tease this data out and see, but I suspect that it's all just a reflection of the hypoxemia rather than other abnormal physiological parameters. Next slide, please. We took some patient feedback. We've actually taken a lot more now, but at this time we'd contacted 65 patients, and overwhelmingly they were extremely likely or likely to recommend this to friends and family. We really felt that this was one of the major wins of the pathway, was actually the patients just felt so reassured by actually having a follow-up and the ability to ring up if they didn't feel right, and also to check their SATs if they didn't feel right. It gave them a lot of reassurance, and that was overwhelming the feedback. Next slide, please. And this is just really a sample of that. Next slide, please. And I don't want to dwell on this too much, but again, it was nice. We did a cost avoidance analysis, and actually we found that even allowing for buying the probes, all the oximeters, and all the additional staff costs, we actually saved the trust around £60,000 for each month that this pathway was running. So that was the icing on the cake, if you like. Next slide, please. So I'm going to finish now, but I just really wanted to go through and just say this was a real team effort. So we got really good support from our management and exec, but like people like medical physics, medical engineering, information governance, they all made this happen, and it really was an amazing thing to see. And the integration with primary care, we think, was fantastic. So I just really wanted to, there's a list of people there, I just really wanted to thank, and especially Joe Noonan, who is probably online and is my ultrasound fellow, because he really was an absolute star when it came to running this. So just to say thank you to him. Next slide, or last slide. That's it. Any questions?
Andy, thanks. That was brilliant. We had a little bit of sound problems during it, so we've actually taken your video off. So we can't see you, but we can still hear you nice and clearly at the moment. Got a few questions for you, if that's okay. So yeah. The first one, how many lung ultrasounds do you think that people had to do before you thought they were safe to practice?
Well, so again, I mean, this was exceptional circumstances, and everyone is slightly different. So what was strange was actually one of the GPs had quite a bit of ultrasound experience, but didn't really sort of pick it up. Whereas actually there were two of the guys who they got it straight away. And as I say, I think the fact that we were using it in a very prescriptive way meant that that particular skill they picked up very quickly. So after probably about 10 scans, they were confident enough to say this is normal. So it was really looking to say whether it was normal, and it was either normal or abnormal. And if it was abnormal, they felt they could go on the pathway.
Okay. And did you revise your pathway when NHSE published their version? And was there any issue with sending or getting your SATs probes back, or are there still quite a lot hanging out there in London?
There's still quite a lot hanging around, but actually we've had to go through infection control and sort out a proper system of kind of recycling the SATs probes. But I think we got about 60% of them back. Yeah, we had basically a system where the patients could come and drop them off into a box, and we gave them a plastic bag to put the SATs probe in, so it was fairly hygienic, if you like. And then we had a system by which we would Jack would clean the probes in a safe way so they could be reused.
And I guess the next question is relating to ambulatory pathways in general. When you do some ambulatory work, a lot of the time the resource from that takes away from the inpatient stuff, and people can't always see that you're doing things when patients aren't in front of you. Did you find that the resource of this took away from inpatient work, or were you quite comfortable with it? No,
because as I say, I mean, if you look, I mean, obviously we were very lucky with the 3 furloughed emergency department doctors, because I think although the PAs did a fantastic job, there were times when patients might ask about other things that the PA students clearly wouldn't have the experience to deal with, other symptoms or whatever. So we were very lucky in that respect. In terms of actually, as I say, I didn't really get that involved with the day-to-day running of it. It was more of a kind of a strategic overview, if you like. And Joe, again, really didn't really do a lot of clinical stuff. It was all more organisational and really just making sure that, again, whenever we got feedback that things weren't working, that we put in the extra teaching materials or extra videos on the website, really just to make it easier for people to access and use the pathway, and for patients to feel confident that they could just go online and have a look at, on the website there's a whole section for patients. So that was a lot of the work was involved. But no, it didn't really take away from other clinical work at all.
Okay. I've got a question here. I mean, this certainly rings true for me. Dan Wilding was asking, they're seeing a lot of post-COVID fatigue and follow-up. Have you got a mechanism for looking at that with this mechanism? Or?
Yeah, so we have actually. We're actually doing some kind of qualitative work with actually one of the ICU sisters who's done a lot of qualitative research, and so we're going to do some interviews with several of the patients who've offered to come forward. So that's one part of it. One of the issues, so again, not specifically around sort of the post-COVID syndrome, but around this, was that we had a huge database of patients who had abnormal chest X-rays, who really, if you're going to follow the BTS guidelines, you would need to follow up with a 6 or 8 week chest X-ray, and you couldn't really devolve that to the GP, so that was problematic. But we kind of came up with a solution together with the respiratory physicians as to how we were going to manage that. But no, I mean, it would be interesting to again maybe go back, do a questionnaire, ring them all again, and ask them whether they have got post-COVID type symptoms. I mean, we've got that data. I'm sure that they'd be very happy to give it, because, as I say, the overwhelming feedback.
They're a happy bunch.
Yeah, absolutely.
I think we've probably got time for a couple more or one more. What proportion of patients admitted based on positive walk tests actually required oxygen or further escalation of care? So I think what they're saying there, was it more helpful than saying come back if you get worse?
So I suppose the question is that the ones that were admitted directly from ED or readmitted?
Yeah.
The ones that were admitted directly, I don't know, because I unfortunately, sadly, all of my sessions when I was doing this were up on ITU.
Yeah.
So I didn't do any acute medicine, so I couldn't tell you about that. Again, so the ones, obviously, we had some readmitted patients who, you can see the proportion. Some of those then were sent home from ED. So, it wasn't completely reliable, but equally there were some patients, there definitely anecdotally were some patients who had an abnormal walk test, who came back into hospital, who ended up on CPAP. So, it was not 100%, but again, we felt we had to do something. In retrospect, our hospital wasn't completely inundated, and I'm sure a lot of these patients, well, not a lot, but we probably could have admitted some of them, but I suppose it just shows that this thing is possible, and if we have a second wave,
yeah,
yeah.
And then I was thinking this as well. We've got a question about whether you think the pathway could be rolled out for other things, so flu or pneumonia. Would that be something we could look at for those things?
Well, so we're really interested in this because actually, there's some guys in Watford who ran a whole virtual hospital. So they had about 1,000 patients because I don't know if you remember, they had a major incident to do with their oxygen supply. And we've been in touch with them, and also Dan Lasserson in Oxford, obviously they're passionate about ambulatory care. And we really do think this is an opportunity to think about, more about how we virtually monitor patients. So the SATS pros were great. There's a lot of really, really clever technology out there now where you can get SATS, heart rate, respiratory rate, some sort of tissue perfusion index. And so we're trying to identify other potential groups of patients who might benefit from this. So like patients with pneumonia, again, who maybe have borderline SATS, more traditional pneumonias, and again, patients with flu. I think that there's scope to put lots of other patients potentially on a similar pathway.
It certainly does look like it. I've got a question of my own, if I can just squeeze it in. Did you look at any sit-stand tests? So we were in our hospital, we were looking at walking patients with SATS probe on, but obviously sometimes in areas like you alluded to in the presentation, it's not always possible because you don't want patients with COVID walking up and down an ED department. So some people were talking about sit-stand tests. Did you ever look at that at all, as opposed to walking people?
As I said, actually, when we first started, everyone was doing different things. So the GPs, I think, had a 50-meter walk test, and then I mean, certainly the respiratory guys were talking about sit-stand tests. But the thing is, we kind of already started, and I suppose we just seized the agenda and said, this is what we're going to do. I suppose the advantage of the sit-stand test is that you can do it and not worry that someone's going to collapse and fall over. But it was just a bit late by then. We'd all elected, and everyone had decided that we would do the same thing.
Andy, that was brilliant. Thank you so much for your time. Apologies that we had a bit of problems with sound there, but I think we got lots out of that. So our next talk is one of the abstracts, and this is about improving asthma discharge for patients going home from the emergency department after treatment for their acute asthma. And it's by Jenny Cooper, who's an emergency medicine trainee. Welcome, Jenny.
Thank you. Yeah, so I currently work at Northwick Park Hospital in London, and I'm going to present a quality improvement project that I carried out this year with the help of Claudia, one of our ACCS trainees, on improving asthma discharge advice for patients going home from the emergency department after treatment for acute asthma. The initial idea for the project came after I discharged a patient with particularly poor inhaler technique, and I realised quite a lot of my ED colleagues weren't checking it on patients that they were discharging, which concerned me. So we carried out some baseline data which had confirmed that a lack of asthma discharge advice was a problem, with only 5% of patients having had their inhaler technique checked, only 10% getting written discharge advice, and only 8% having been advised to see their GP within 2 working days. So plenty of room for improvement. We aimed to increase the percentage of patients who were discharged with appropriate discharge advice to 80% by May of 2020. And we defined appropriate discharge advice as having to meet all 5 of these outcome measures, which were based on the BTS guidelines. So patients should have had their inhaler type and technique checked, be given an adequate dose of prednisolone, be given written advice, and be advised to see their GP within 2 days. We used IHI methodology throughout the project, so we used multiple PDSA cycles to try to improve asthma discharge advice. Some of our change ideas were more successful than others, and with our continuous measurement of 10 patients a fortnight, we were able to see quite quickly what the effect of the changes were. So we were able to either persevere with them or abandon them, which was the case in 1 or 2 of them. The first most obvious intervention was to introduce a written asthma discharge plan, because at the time we didn't have anything specific in place, and trying to convince my ED colleagues to complete the full Asthma UK action plan didn't seem overly feasible. So I made some amendments after speaking to some of our respiratory colleagues and got permission from our ED consultants to introduce it, which we did at the start of October. Following that, there was a small increase in the percentage of patients who were discharged with written advice, but not much of an improvement in the other areas, which probably wasn't surprising. Therefore, the next thing that we tried to do was introduce a discharge checklist sticker, which was inspired by the BTS asthma discharge bundle, but with some amendments, again, after speaking to some of our respiratory team, as well as ED consultants, and having a focus group with some of the ED juniors just to check understanding. That was introduced at the start of December to coincide with our F2 changeover. So I was able to introduce it at induction, as well as the usual advertisement through handover and emails and WhatsApp communication. Following that, there was a few people who had all 5 of the outcome measures met for the first time, which was great, and they had the discharge sticker used, but unfortunately the uptake of it was still very poor. So for PDSA cycle 3, we decided to design eye-catching posters to have around the department to try to encourage its use, because when the sticker was actually used, it seemed to help. It just wasn't, the uptake wasn't great. We also had posters in patient areas trying to engage patients with asthma education, but unfortunately that didn't have any effect whatsoever. So instead we decided to introduce an electronic pop-up reminder, which now comes up whenever the diagnosis is coded as asthma on Symphony, with a reminder to give written advice and to see the discharge checklist. Symphony is the electronic patient management system that we're using in RED. Alongside that, in the interest of making it quick and easy for staff, we also were able to get the written asthma discharge plan to come up automatically whenever the GP letter is being printed, which I think was probably one of the more successful interventions that we tried. So following that, the only real area of weakness was still trying to get people to check inhaler technique. So PDSA cycle 5 was meant to be an asthma box, which I'd placed in our clinical decision unit, or CDU. And I was planning to bribe staff to use it basically with chocolates and stuff, and was planning to attend some of the nursing study days to try to get them on board as well. Unfortunately, my timing wasn't great because I put the box in CDU on the 5th of March, and I think by the 7th of March we didn't have a CDU anymore because it became our suspected COVID area. So I think even with infection control measures, I haven't been able to reintroduce it just yet. So unsurprisingly, given that it was pretty much abandoned, inhaler technique checking still a work in progress, which you'll see from our results. So this is a run chart showing our progress with the overall asthma discharge advice. So having to have met all 5 of our outcome measures. You can see we've got a very low baseline, and we did make some improvement, but unfortunately we were still quite far off our aim of the 80% for our overall asthma discharge advice. But when we broke it down by the different aspects of discharge advice, you can see that it's really only inhaler technique that was limiting our overall improvement. We did make significant improvement in the other areas of discharge advice. And just to look in a bit more detail at some of the outcome measures, this run chart showing the percentage of patients who are getting written discharge advice. So you can see there's a shift after the PDSA cycle 1, which was the introduction of our written plan, with a run of 6 data points above the baseline median, which was a signal of non-random variation. And then even from the new improved baseline, there was a further significant improvement after PDSA cycle 4, which was the changes that we made to Symphony. And similarly with the patients being advised to see their GP within 2 days, you can see there was a shift again of 9 data points above the median line after the written plans were introduced. And again, there was a further significant improvement even from the new baseline following the changes to Symphony. So in conclusion, relatively simple changes can be effective so long as they don't significantly increase the workload of busy staff. Modifying the existing electronic system allowed us to get people to give written advice and could be used in other EDs and AMUs with similar electronic systems. And I actually found that making the electronic changes to Symphony was a lot easier than I had expected. Thanks for listening.
Thanks very much, Jenny. That was great. So why do you think it is that people have a particular issue with showing people how to use an inhaler? Do you think they don't know?
So we had actually collected process measures as well during it. So I'd done a couple of staff surveys, and everyone claimed that they knew how to check it and that they knew that it should be checked. And yet I still couldn't get people to do it. So I don't know if there's partly a time thing, or I guess once COVID started kicking off, it was a little bit of worried about taking the mask off, that sort of thing. But I've not quite got to the bottom of it. It's still a work in progress. We've just tried to change the checklist over to try to get it on Symphony as well. So hopefully more reminders, etc., will help.
Okay, so a couple of questions from the floor. So recognising some of the challenges patients might have in getting timely GP follow-up, did you explore any ideas or mechanisms to support discharge of these patients from within the hospital?
So we had initially, we did a bit of a research before we started in terms of what had been tried before and a bit of a literature search as well. And we had previously tried to get patients followed up through our ambulatory care unit, but there were issues with funding and it not thought to be emergency care. So in the interest of making our project achievable, we tried to change the things that we had control over. I don't think there was any chance that I'd be able to affect the GP appointments, but at least if they had safety netting and advice on self-monitoring, at least hopefully they would at least come back to us if they weren't able to get a GP appointment, if things weren't going the right direction.
Okay, and you improved the part regarding recommending GP in 2 days. Do you know if that this actually got followed up? I mean, did you get any documentation from that? No.
We were measuring like reattendances, but it was quite low numbers, so it didn't really change at all. So
And in terms of, do you have an asthma nurse? Were they able to help out with the linking in with the community?
I was got one of the respiratory nurses involved, and she was quite keen that patients that had come to ED 3 times a year were referred to them. But unfortunately, with staffing and them already being really busy, they weren't able to. They were the ones that had initially tried to follow up with ambulatory care, but I think just staffing wise, it wasn't feasible, unfortunately.
That's brilliant. I think the question on there is the same sort of thing. It's looking at how we get these patients followed up quickly, and it's a time problem, isn't it? And then, bless, when COVID hit, right in the middle of that, it's not helpful, is it? So I'm sure it will be interesting to see how that then goes now with COVID settling down, hopefully, a little bit. The question just come through about suggesting people follow up with the asthma nurse in the practice, not the GP. I sort of echo that. You sort of get an appointment with the asthma nurse a bit quicker, don't you? So, and asthma nurse is probably much better at checking technique than doctors. Probably very true as well.
Yep.
Okay, that's brilliant. Thank you very much, Jenny. Okay, so we're going to move on now to our next oral abstract presentation. This is a double act. We've got Sophie Foreman, who's a CT1, who's going to give us the presentation. And then Philip Malloy, who's also a CT1 ACCS trainee, is then going to take the questions. So do colour-coded lanyards in the acute medical unit help identification of doctors and improve effectiveness of communication? Be interested to see. Okay, thanks, Jenny.
Hi, thank you. So my name's Sophie. I'm one of the ACCS trainees working at the University Hospital of Wales in Cardiff. That's my colleague Phil, who's also the same. So we're going to present to you today a quality improvement project that we carried out in our medical assessment unit from November to January. So this is looking at whether colour-coded lanyards in the assessment unit can improve identification of doctors' grades and improve the effectiveness of communication. So I'll present it, and then Phil will answer any questions at the end. So just a bit of an overview about what we'll talk about today. So we'll go through the issue that we identified in the medical assessment unit, the aims that we set out for our project, how we went about carrying it out, the results that we got, a few limitations that we came across, the conclusions that we came to, and then where we think that we should go from here with our project. So just a bit about the issue. So the University Hospital of Wales is one of the largest and busiest hospitals in Wales, with a very large and busy medical assessment unit. Therefore, there's a high flow of clinicians rotating through the department, and often staff aren't familiar with each other and aren't aware of each other's training grades. So this can lead to staff often wasting time trying to find the correct grade of doctor, and often approaching the incorrect grade of doctor for advice as well. And in addition to this, during the assessment of acutely unwell patients and cardiac arrest calls, this lack of familiarity and knowledge of each other's training grades can have a negative impact on team working. So the aim that we set out was to see whether introducing colour-coded lanyards into the assessment unit can improve identification of doctors' grades and improve the effectiveness of communication, hopefully helping to reduce the time spent trying to find the correct grade of doctor. And in addition to this, during the assessment of acutely unwell patients and cardiac arrest calls, helping the ease of identification of a doctor's grade and therefore level of skill set and competency, helping with more efficient task delegation, team working, and optimising patient safety. So moving on to the methods. So we sent out questionnaires pre and post intervention to all staff members on the medical assessment unit from all members of the MDT. So this is our pre-intervention questionnaire, so asking the person filling the form to specify their role, how easy it is they feel to find the correct grade of doctor on a daily basis, if they think that a visual aid such as colour-coded lanyard would be helpful, if they think it would help reduce time trying to find the correct grade of doctor, and if they think it would be helpful during a cardiac arrest. Following this, we then introduced the colour-coded lanyard onto the medical assessment unit over a period of 2 months. So we obtained some charity lanyards of 5 set colours, as you can see here. We would hand them out at the beginning of each week, as there would be a new on-call team each week, explain the project. We would send out emails to all staff members, and we put these posters all around the department to explain which colour corresponded to which training grade. So after that 2 months, we then sent a questionnaire out to all staff members on the medical assessment unit, again asking them to specify their job role, if they felt that the lanyards were a useful visual aid, if it helped them identify the correct grade of staff, if it helped them save time finding the correct grade of staff, if it was helpful during a cardiac arrest, and then a section there for any additional comments. So moving on to our results. So our pre-intervention questionnaire, we had responses from 29 members of staff from a variety of professions within the MDT. So this found that just 21% of staff members found it easy to find the correct grade of doctor, 62% felt it at least sometimes difficult, and 17% found it was difficult. 93% felt that the lanyards would be a useful visual aid, 83% felt that they would help to save time finding the correct grade of doctor, and 79% felt that they would be helpful during a cardiac arrest call. And then our post-intervention results, so this was from 28 staff members, again a variety of staff members. So this found that 93% of staff felt that the lanyards were helpful in identifying the correct grade of doctor, 96% felt that they were a useful visual aid, 89% felt that they helped save time identifying the correct grade of doctor, and 46% felt that they were helpful during a cardiac arrest. However, the remaining put not applicable, and actually 0% put no for that answer. So common themes from the additional comments were that it would be useful to have the training grade on the lanyard in addition to the colours, and that it should be rolled out trust-wide rather than just in the medical assessment unit. So a couple of limitations that we came across during this quality improvement project. So we set out a set number of lanyards at the beginning that we thought we'd need. However, we'd find that often staff members would keep the lanyards and use them on their wards on a daily basis. So we ran out a bit quicker than we thought, but we were fortunately able to obtain a further supply. Now these lanyards were charity lanyards, so they came in a set 5 colours, so we couldn't choose the colours. And for example, the consultant lanyards were quite a bright pink colour, which weren't necessarily everyone's preference. And with these colours, the staff members on the medical assessment unit needed to reference to the poster to see what colour corresponded to what training grade, which isn't necessarily always practical. The questionnaires, so we sent the pre and the post questionnaires out to all staff members of the medical assessment unit, but the responses from either questionnaires weren't necessarily from the same staff members, so it wasn't completely comparable in that respect. Staff awareness. So as I mentioned before, there's a high flow of clinicians rotating through, so it was important for us to keep on top of staff awareness by mentioning it in handovers, by putting the posters up in the emails, and it was departmental, so only in MAU. So again, really important that we kept on top of the awareness and made sure everyone knew that this project was happening when they were coming down to MAU to work. And then compliance, generally everyone was really happy to wear the lanyards, but for example, one junior doctor just preferred their own lanyard. So in conclusion, the use of colour-coded lanyards does help to improve the identification of doctors' grades within our medical assessment unit and helps to reduce time spent finding the correct grade of doctor. They're helpful during cardiac arrest calls, however they do need a bit of adjustment, so with the addition of the training grade on the lanyard and a little bit of alteration to the colours. So where do we think we should go from here? So hopefully we can get some funding for some new lanyards and adjust the colours. So for example, we'd like to change the consultant lanyard from a pink to a black. We would like to have the addition of the training grade in big bold writing on the lanyard, so staff and MAU don't have to reference to the posters. We hope to introduce these in the medical inductions and then re-audit in 2021. And then if we're successful, hopefully we plan to expand this out to all departments and an all Wales scheme if possible. Thank you. Any questions?
Thanks very much. So are we getting Philip up for the questions? Is that right?
Yes.
Lovely. Are you there, Philip?
Yeah, can you hear me?
We can, yes, and we can see you now. Great, welcome. And this is brilliant. So before we go into the questions, why are you planning on changing consultants from pink to black? I'm curious. I'd be gutted.
Interestingly, it wasn't really the male colleagues who didn't want to wear this feminine colour. Lots of our female consultants who newly qualified as consultants from registrars felt that it was quite a derogatory sort of colour to wear, and they were trying to move away from that sort of what they called Barbie pink. So it was widely accepted that black would be a much more gender neutral and much more sort of socially acceptable colour to wear.
Okay. Lots of questions regarding infection control. That seems to have piqued interest amongst our listeners. So sure. Do they have any objections to infection control, and how have you managed that?
So this was all done pre-COVID, and pre-COVID policy in the trust was to use lanyards. During the outbreak, several colleagues have been using just a badge with a small clip on there. And Sophie and I were discussing about whether or not we could create name badges of different colours instead, the background being different colour, or a smaller lanyard strip attaching to that of a different colour.
So have you lost lanyards completely during COVID?
I would say the majority of people still use them in the assessment unit. We've gone to scrubs, obviously, but the majority of staff still use lanyards within our trust. I saw a registrar today who was wearing his bright orange lanyard and was quite easily identifiable across the floor.
I mean, I think maybe if people want to add that to the chat who are listening, it's quite the people. One of the questions is interested to know how many people have still got lanyards. One of the other questions is, did you find that it was actually other members of the MDT that had more difficulty identifying which grade of doctors were rather than doctors themselves?
No, we found that both people found it as easy or difficult. There was no real change in responses. If anything, the main issue actually was educating people on what an F1 was, what an F2 was, what a core trainee was. And the initial thought was to use the colours, if we could have chose them, was to go, with danger of sounding, again, derogatory, is go from cold blue to sort of hot red, to the hotter the colour, the sort of more experienced the grade of doctor. And that's what we kind of tried to reflect. And if we got that message across to our sort of nursing team, they were able to sort of buy into what grade doctors were and who was who. The orange one particularly was particularly bright and helped identify the registrars who often made a lot of the key important decisions.
Somebody's just put on the question and answers, maybe you should colour people's scrubs rather than their lanyard to identify people.
I completely agree, and it's an interesting thing that nurses often wear uniforms. So within the hierarchy of nurses, they have different coloured uniforms or piping to identify their grade. Yet as doctors, we don't do this. Obviously now we're in an era where we're all wearing scrubs, and it'd be interesting to see if that continues, particularly in the assessment unit and the emergency department. And it could be one avenue we explore.
Okay, it's brilliant. Thank you so much for your time, and thank you for coming.
Thank you.
Okay, we're going to move on now to our final abstract today, and that's pathologies, outcomes and complicating factors in inpatients with habitual illicit drug use. And that's Claire Mason, who's an ST3 in acute internal medicine at the Royal Free. Welcome, Claire.
Hi, I'm Claire. I'm one of the ST3s at the Royal Free Hospital, and this is work that I undertook with Dr. Gajendra Sandhu, who's a ID consultant at Ealing Hospital. And I'm going to talk about the pathologies, outcomes and complicating factors that we saw in inpatients with habitual illicit drug use. So deaths due to drug misuse have been increasing in the UK, and in 2016 to 2017 were the highest on record. And about 3.5% of adults take Class A drugs every year in the UK. And this leads to a variety of problems, the local complications, for example, of injecting or smoking drugs, bloodborne infections, but also immunosuppression, which can be for example, to do with the bloodborne infections such as HIV, but also a direct effect on cell receptors of the immune system by opiates, for example. And also social problems such as homelessness. And you can see that those three factors, the drug use, homelessness, and poor mental and physical health, can all interact with each other and exacerbate each other. Homelessness is at a record high in the UK, according to Crisis. And in areas such as in Southall, where Ealing Hospital is, this is worsened by gentrification of more central London boroughs. And there are worsening health inequalities in the UK, as reported on earlier this year in the Marmot report, which again exacerbate all of these factors. So we looked back at patients admitted to Ealing Hospital between February and July in 2019 who had illicit drug use mentioned on their discharge summary or who were referred to our local drugs and alcohol team whilst they were inpatients. In that time, we had 37 admissions of drug users, which was comprised of 23 individuals. So you can see that there were quite a lot of readmissions in that group. 4 were female, 19 male, and their age range was between 29 and 61. And 57% of those patients were homeless. You can see that most of them were using IV heroin, and some of them were also smoking heroin, smoking crack especially, and some of them using cannabis as well. And 30% of them were hepatitis C positive. A lower proportion were HIV positive as well. And the average length of stay was actually very long, so 15 days, reflecting their difficult social situations, but also some of their very severe pathologies. And you can see that their pathologies were quite wide-ranging. So nearly half of them were infections, which were comprised mainly of lung infections, so pneumonia and lung abscesses, but also of skin infections and localized abscesses, infected DVTs, and also a couple of brain abscesses. And other presentations were with exacerbation of lung disease, largely due to heroin and crack smoking, complications of diabetes, injuries, possibly compounded again by drug use, alcohol, and also the poor social situation these patients often live in, and a pneumothorax, which was secondary to heroin smoking. And you can see from the point of view of the microbiology in those with infections, there was quite a wide range of infections detected. So the 6 bacteremias, half of them were Staph aureus, but also there was a Klebsiella, for example, and then a wide range of other bacteria, which they grew mainly in sputum, also in wound swabs. And we found that they had a wide range of complicating factors as well. So from the more medical side, the comorbidities included blood-borne viruses, as we've already discussed, diabetes, which was quite common in these patients and tended to be very poorly controlled, psychiatric comorbidities, which were often undiagnosed and untreated, and alcohol dependence. We also had a lot of difficulties medically with drug interactions, particularly with methadone, but also with antiretrovirals, making our treatment of them a bit more complex. Pain management was another difficulty in some patients. Doctors were quite reluctant to give large doses of opiates to these patients who were already addicted to drugs. But equally, they were very tolerant of many painkillers, and so this made it quite difficult to manage. And many of them came in with recurrent complications as well. And in terms of the more behavioural factors that limited our care, there were a lot of absences from the ward amongst this cohort of patients, and poor compliance. And this was it was very difficult, for example, in those patients who needed regular IV antibiotics, for example, regular blood glucose monitoring. There was also use of drugs, alcohol, and cigarettes on the ward, with many patients saying that they didn't know they were not allowed to use them on the ward, and also illegal activities in the hospital, both on the ward and in the hospital grounds, and those included drug dealing and prostitution in the ward. This was exacerbated by having quite a lot of patients admitted at once who had some of these problems, who knew each other and also were used to dealing drugs with each other. In terms of our outcomes, 3 of these 23 patients died in that time, and they were all repeat admissions. And 40% were discharged to no fixed abode. 80% didn't attend their follow-up with the infectious diseases team that was offered. So that again contributes to recurrent readmissions. So some of the suggestions that we had was we developed a patient contract, and that was to really reiterate to the patients when they came to the wards, the ID ward or AMU, that there were certain rules in terms of behaviour on the wards. So things like not drinking alcohol on the wards, not smoking on the wards, not using drugs on the ward. And having that very clearly laid out made it much easier for our nurses to report the problems, and for staff to enforce actions such as giving a written warning or asking these patients to leave the hospital. But it made the relationship between the patients and the staff a bit easier because everyone was very clear with each other. We also instituted more liaison with charities such as St Mungo's, which provides one of the homeless hostels in the Southwall area, and social services, the local council and the police, so that we could talk about some of the community problems that we were having. And we have wondered about a standardized approach across different hospitals, because what we did notice is that sometimes our patients would then be discharged and go straight to a nearby hospital. And so perhaps having a similar set of rules, but also ways to help these patients, and ways to set up follow-up and liaise with the community would be really useful if we had those across London or even across the UK. So thank you. And if anyone has any questions, I'm happy to answer.
Thank you very much, Claire. It's a really difficult problem, isn't it? One of the things I'm interested in is what you think about ambulatory care for these patients. You alluded to the fact that 80% of people don't turn up for follow-up. We don't really tend to admit DVTs or possible DVTs in anybody else, but in these patients, the guidelines are often to admit them because they don't tend to come back. What's your thoughts and feelings on that?
The part of the problem with ambulation, for example, with antibiotics, is of course that we don't really want to send people home with a line, and we didn't send them home with DVTs either, partly because, as you say, they had such high risk of not coming back, partly because they often also had complications with those DVTs, so they were not just simple DVTs that we could treat just with anticoagulation. A lot of them were infected, for example.
Dan Wilding was wondering how you decided how to draw up a contract with which patients you could draw contracts up. Did it stigmatise certain people by saying that, oh, you can have a contract?
I think that's a really good question. I think it was for the patients that we knew were IV drug users. A lot of these patients were known to us from problems in the past. I think in patients where there was doubt, we probably wouldn't have used it, but in patients where we knew that we'd had problems before, those were the patients we used them with initially. And
were they receptive to it?
Yes. After that, we actually had fewer patients coming in, so it's a bit more difficult to judge. I think partly I think they did accept it, but also I think they felt like it was us becoming a bit tougher on them. And so there was definitely a move away to some of the other nearby hospitals after that as well.
Okay. Somebody's questioning whether you actually have any other pathways apart from just medical ones. Are the surgeons doing this? Like, for example, you alluded to this with the DVTs. They often come under the vascular surgeons.
Yeah.
Is this happening with those as well?
So they hadn't yet. We'd only sort of looked at it more on the medical wards, on ID particularly. So they hadn't yet. So it'd be worth talking to them about that, because often they were patients who had comorbidities, but on, for example, as you say, a vascular ward or an orthopedic ward, for example. And so I think it would be useful having it sort of hospital-wide. Yeah.
And very quickly, we'll squeeze one last one in. Do you have any thoughts about alternative methods for delivering care to patients who habitually use drugs?
So I think what's really important is the involvement of the community services as well. Liaising, for example, with St Mungo's, so that we could liaise with them about follow-up, etc., and social services. I think the major problem with these was not, as you were alluding to, the medical issues. It was more what happens afterwards and in between. Some of what we've seen within COVID has been that patients, for example, with hepatitis C have been treated much better because a lot of them were within hotels. I know one of the hepatologists at Royal Free was telling me that actually they've managed to treat a lot of hepatitis C recently, which has been really great. So it was one of the really good outcomes of COVID. So that really does highlight how it really is the community aspect and the housing and the stigma in the community that is, those are the really important issues to tackle, rather than what's actually what we're seeing as inpatients is just the sort of tip of the iceberg.
Claire, I'm sure there's a couple more questions if you can answer those after the talk. It's lots of people thanking you for raising this as a massive issue, so thanks very much. And I'll take this opportunity again to thank all our speakers tonight. So we're going to move on now to our next poll questions to finish the evening. So now we've had the talk, can you rate your understanding of triage into the community of COVID-19, the virtual ward? Okay, so definitely more understanding following Andy's talk, following that. And can we get the next poll question, please? And again, could you rate your understanding of management with the ED-led ambulatory pathway? And again, showing a much better understanding of these. And finally, we've got one last question for you regarding the day of the week. Just want to know whether you are happy with Tuesday. Is it a better day or makes no difference? If you could vote on that for us, please. And okay, some people are saying better and a lot of people saying makes no difference. So that's great. So our next slide, sorry, should be the advertising of the next seminars. So we've got one on the 18th of August and one on the 29th of September. Remember that these are available online if you can't make them real time. And thank you very much for coming in. Thanks very much for the speakers. It's quite nerve-wracking speaking to an empty room, but I think you'll agree everyone did brilliantly tonight. And thanks very much. Good night.